Nolte Chapter 6 is about the blood supply of the brain. So an overview of the blood vessels and structures of the neck coming up from the heart and going up the neck into the brain. So let's start at the bottom left-hand side here. So you can see the aortic arch here. So we have the heart, and then coming off of the left ventricle area here, so kind of behind there, we have the aortic arch coming up. You guys can see why I was a science major and not an art major there, right? So coming up here, okay, is this right here. So aortic arch, and you can follow this up here. This is the common carotid, and then it's going to bifurcate or split off into two. We could see the external carotid here, and then I'm going to switch colors to yellow, and then the internal carotid coming through here. You can call this the cervical part because it comes through the neck, and then we can see the internal carotid, what we call the cerebral part up here. And then you can see the posterior communicating artery right off of there. We can see PCA, posterior cerebral artery here. But let's not get ahead of ourselves here. Let's go right back down here. I'm going to switch it up into purple and come up and around here. You can see this subclavian artery, so under the clavicle. And then you can follow this artery up here, and you can see that it's going in the little holes in the transverse foramen here. The little holes in the transverse process are called the transverse foramen. So coming up through here, it's going to be on both sides. So that vertebral artery is going to come up, and it's going to join and become the basilar artery right here. Okay, I think that's all we really want to point out off of this slide here. So the next slide is a blank one of this, so you can pause and take some time to kind of go back and forth between these two slides. I'll go ahead and erase some of this here so you're not stuck with that. All right, so let's go to the next slide. And pause here, take your time, write out the words. It's a helpful way to study anatomy is to write it out and start to picture where these things are. So what's going on with this slide here is, I'm going to start at the very bottom here. We have our spinal cord area here, and then we have medulla, pons, midbrain area, and then we can see the vertebral artery is this area right here. These two arteries come up, combine, and form this basilar artery right here. So this little divot in the pons for this artery is called the basilar pons. So we see this basilar artery here. I'm going to go ahead and erase this so it doesn't look so busy, because this slide already kind of looks a little busy, right? Okay, so I have a blue marker here. I'm going to point out a couple of landmarks for you here. So up top here, cranial nerve number 1. If you can see my blue pen moving there. So cranial nerve number 1, olfactory nerve. And then the eyes have been cut away. So this right here, this crossover in the center. So we have optic nerve on this side here, and most of it has been cut away, and the eyeballs obviously have been cut away. And then it crosses over at what we call the optic chiasm. And then down here you can see cranial nerve number 5, or trigeminal, right here as well. So just kind of orienting you to where you are here. And then I'll take my green marker and outline the cerebellum right here. Okay, so occipital lobe would be in this area, so obviously this is posterior and this is anterior or frontal area right here. I'm going to outline the temporal lobe, so if you look to the left, look for the green marker here, so temporal lobe right here. Okay, so I'm going to erase a couple of these things now so we can kind of have a clearer view. So we'll label this in a couple more slides, but it's a little busy if you don't know the pieces parts of this. So it's not the one you want to learn off of usually, but we'll look at it again later. What we're going to do is we're going to follow this path here. So we're going to look at these vertebral arteries, basilar artery, and then this circle in here, what we call the circle of Willis. Okay, so it kind of looks like a person. I don't know who Willis is, but probably the doctor that named it, or they thought it looked like Willis. I don't know. So we're going to go ahead and look at that circle of Willis to help this picture make a little bit more sense a little bit later. So here again is that same view. So front, back, and then I'm going to use yellow in the center for foramen magnum right there. Okay. So we're going to look at this a little bit more in the other slides. This is just to help orient you on where this is in space. You can do this one if you want, but you could do it later if you want. Okay, this one is a little bit easier to learn off of. So that top picture there, we have the basilar artery. So we have the vertebral arteries coming down through, well, they'd really be coming up from the heart. All arteries come from the heart. And it would be coming through the transverse foramen and then become the basilar artery. And then the very next one we have coming off of here is the PCA, or posterior cerebral artery. Next up, I'll switch colors here to blue. This area right here is the posterior communicating artery, or what we call PCOM, P-O-C-O-M, PCOM, posterior communicating artery. And then we can see here, remember that internal carotid coming up? This guy? Okay, so he's coming up. So you have to kind of remember that first slide where we saw the vertebral basilar as an artery coming up, that backside there, and then more anterior to that we saw the internal carotid coming in. Okay. And then here, coming off of that area here, we're going to call this the middle cerebral, or MCA now. Okay, so internal carotid, middle cerebral. Coming up, I have a purple marker now for you to see. Anterior cerebral artery, or ACA. American Chiropractic Association, right? Nope. Anterior cerebral artery, and it's this all the way up here as well. Okay, so ACA. This little guy in between is called the anterior communicating artery, right there. Okay, so go ahead and practice that on the bottom. So pause this slide here. I will erase this stuff here, make it a little bit easier for you to reference it back and forth. And then what I do is I just draw it out over and over and over and over again until you get it right and cannot get it wrong, because you've drawn it so many times that your hand just has muscle memory for the circle of Willis. So go ahead and pause, take your time, draw it out, and I'll see you for the next slide. This slide here is a little bit more complex than the previous one, but you have the basics already, right? So we have our vertebrals, okay, at the bottom. You can see that green marker that I have there. There's a highlighter, try that. Green at the bottom there. Yeah, that's kind of cool. So our vertebral artery becomes our basilar artery here. We see these little pontine arteries here. That just means it's going to the pons, remember. And then we have superior cerebellar. Okay, so note that it's not cerebral, it's cerebellar, so it's going to the cerebellum. And then the posterior cerebral artery here, PCA. And then PCOM, posterior communicating. And then we see that internal carotid coming in, remember, that was a different source from the neck. And then we see middle cerebral here. And then we can see anterior cerebral artery, or ACA, okay, all the way up through here. Okay. Then the little guy in the middle is that ACOM, or anterior communicating. Okay. Anterior communicating. So what do we have a little different here than last one? We're adding in, if you look at the bottom here, posterior inferior cerebellar artery, or PICA. And if you look towards the middle, ICA. So we have a posterior inferior cerebellar artery and an anterior inferior cerebellar artery. Okay. The other cerebellar is right here, superior cerebellar artery. And then if you look in the middle of those vertebral arteries, that's new to this slide as well, this is the anterior spinal artery, going down the front of the spinal artery. Good. Next slide. Okay, so hang out with this slide and just draw it over and over and over again, or what else you can do. What I did was I just took a piece of paper, or I used the whiteboard and just drew this myself instead of using this plus the blanks. Draw it myself and then just keep labeling it over and over and over again, and keep labeling it in the same order in order to create a muscle memory. So pause and take time to learn these structures. So this is the main focus of this chapter, is this area right here. So vertebral basilar circle of Willis area here. So this might be a little easier to understand now. So let's take a little time with this. So I've got my red marker, my red highlighter. So cranial nerve 1 up here, 2 in the optic chiasm here, and I'm moving to green, going to show you temporal lobe. Okay, and I'll do blue for cerebellum, is back here. We could then tell that this here would be occipital, and up front here would be frontal lobe. So now that we're kind of oriented on where we are, let's go to the vertebral. So I'm going to erase these so it's not so extra busy. All right, let's go up vertebral here on both sides. You can now see that anterior spinal artery actually where it would be. So in the spinal cord area here. So coming off of here. And let's see, where else do we want to go here? Well, let's go basilar. So we have vertebral to basilar here. And then I'm going to move to yellow so you can see it better. And then you could see the superior cerebellar artery coming off of right there. Right? Superior cerebellar. And then who's next on our list here but PCA, posterior cerebral. And then PCOM, posterior communicating. Coming up and around. And then we can see our internal carotid area, this guy there, and middle cerebral. Remember that that is a different source coming up the neck. So remember that first slide. So we have that vertebral coming up, that more posterior aspect of the neck, and then we saw the common carotid coming up and internal and external carotid. This middle cerebral is going to duck under here, so you could see it if you retract this temporal lobe area here. And then we can see anterior cerebral coming up. This guy's got him coming all the way around here. And then ACOM, anterior communicating, right there. Right in the center. It's hard to see, so I'll grab dark blue so you can see it. There we go. Okay, so the next page has the blank ones for you, and you can practice that yourself, drawing that. So pause here and take some time to practice. Let's look here at the arteries that supply and nourish our spinal cord. You can see the posterior spinal artery is responsible for that light blue area, so that's our dorsal columns, that fasciculus, gracilis, and cuneatus. The vertebral artery is going to be where that pink area is, and then the anterior spinal artery is going to be where that greenish yellow area is. So a simple way to remember this is kind of color-coded here for helping our memory. So the yellow is going to be anterior cerebral artery, red is middle cerebral artery, and blue is the posterior cerebral artery. So this is the territory that these blood vessels serve and nourish. So we'll look at this on the next slide as well. Here is the same picture as the previous slide, but blanked out for you. So you can look at the yellow and write anterior cerebral artery, look at the red, write middle cerebral artery, and look at the blue and write posterior cerebral artery. It seems extremely simple to do, but if we make it that simple and use these primary colors and have you write it out and color coordinate it that way, it tends to stick in your memory a little bit longer, is the hope. In this schematic, we're looking over here for medulla, pons, midbrain area, and then what blood supply is going to be responsible for what area. So we would see this area right here. If you look to the left, that's the medulla, here's our pons, and then our midbrain. And so medial medulla is going to be anterior spinal artery. Lateral medulla is going to be the pica, or posterior inferior cerebellar artery. Pons area, we're going to get blood supply from the basilar artery for our medial pons, which makes sense. There was that vertebral artery and then the basilar pons area there right in the middle. And then ICA, anterior inferior cerebellar artery, is going to give blood supply to the lateral pons. And then PCA, or posterior cerebral artery, is going to supply both lateral and medial midbrain. If you look to the right, this schematic is also part of the rule of fours for our cranial nerves. So medulla, pons, midbrain, and then above the midbrain, cranial nerves 1 and 2, which are really brain, are up there. And but this schematic right here, we just number 1 through 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and we know that 9, 10, 11, 12 is medulla territory, cranial nerves 5, 6, 7, and 8 are pons territory, and then 3 and 4 are midbrain territory. And then what this is denoting is that 12 is medial or midline, so is 6, 4, and 3. So 3, 4, 6, and 12 are midline structures. And what we see here is that they're divisible by, it goes into 12, right? So 3 times 4 is 12. Okay? 6 times 2 is 12. So that's the little mnemonic. We call it the rule of 4s. I did not make that up. There are PubMed, there's a PubMed paper on it, and it is called the rule of 4s. So 1, 2, 3, 4 up in midbrain and above, and then pons 5, 6, 7, 8, and then medulla 9, 10, 11, and 12, and then 3, 4, 6, and 12 are midline. So then that means 5, 7, and 8 are lateral pons, 9, 10, 11 are lateral medulla. Super complex sounding, I know. We'll go through this over and over again in other chapters as well, and it'll start to make sense when we try to localize the lesion, or where did somebody have a stroke and what symptoms are showing up because of that stroke. And so we'll be able to figure out what part of the brain has a deficit because of what cranial nerve is obviously not working well. And then we'll be able to localize that to medial or lateral aspects of medulla, pons, or midbrain. And because of that, we can then use what we have over on the left there to determine the blood vessel. So yes, of course, the hospital would have determined the blood vessel, right? That was at fault for the stroke, but it is an anatomy lesson for us to be able to localize the lesion, and then it helps us with neuro rehab in order to know what aspect, medulla, pons, midbrain, or what cranial nerve is affected. So the blood supply overview. We haven't had blood supply specifically yet, so I want to touch on the overview of how the body works with blood supply. So we have the heart, and a pretty basic picture of it there for you to follow along. So we have our heart, and then from the heart comes the aorta, which is the largest artery of the body. Then we call them arteries that come off of that. And the tiny arteries are called arterioles. Then we have the capillary bed. And that is where the blood is going to come out of the blood vessels and no longer be blood. It's going to be interstitial fluid, which is basically lymph, but with the good stuff in it still. Lymph is seen to be the end product after the cells get what they want. So this clear exudate, or this clear secretion or ultrafiltrate, comes out as interstitial fluid at the capillary bed, and that is what nourishes your cells. So your cells the parenchymal cells, the functional unit of the body, those cells don't actually get straight blood supply, blood to those cells. It is to the capillary bed, and then the filtrate of the interstitial fluid is what is actually nourishing the cells. So minor detail there. We think about, blood supply to the area, but it's actually interstitial fluid that's coming out. And that happens in the capillary bed. And then it gets carried along in the lymphatic system. So it's interstitial fluid, that's the good stuff, and then the lymph, it's not really bad, but that would be the bad stuff or the garbage afterwards. But there's plenty of good stuff with it, but that's just a simplistic view of it for understanding it at this level. So the interstitial fluid doesn't come back in as blood. is the point. So we have the artery, arterial, capillary, the blood that stays in there, right, is now going to be venule. So the oxygen has been taken to the cells, right, and then it's been the carbon dioxide has been picked up, and we're carrying that out through the venule here. So venule would be next, and then vein, and then heart. So we have heart, aorta, artery, arterial, capillary, that's where the exchange happens, venule, little teeny tiny vein, and then our veins and our heart. So note arterial and venule, they have the same kind of feel to the end of the word. So it's an I-O-L-E for arterial, it's a U-L-E for venule, but they still give you that same kind of feeling. And what that is that's diminutive. So it means whatever's in front of that word part is smaller. So we'll see this in bronchiole as well. Those are really small bronchi as part of the pulmonary system when you study that. And so you'll see this theme kind of show up every once in a while. Principal vessels of the systemic circulation. So we see diagrams of oxygen-rich blood shown in red, whereas oxygen-poor blood is shown in blue. We see schematic flow charts or these pipe diagrams showing vessels that are closer to the surface in brighter colors, whereas the vessels that are deeper are shown in darker shades. So this is just how we're going to be able to study something so 3D and moving in a way that we can see it in slides and in books. Tips for memorizing. So name of the blood vessel usually reflects the body region being traversed. So axillary for the armpit area, brachial for the arm, femoral, femur, etc. Or the organ being served. So renal, kidney, hepatic, liver, gonadal, gonads or reproductive organs. Or the bone being followed, vertebral, radial, tibial. Arteries and veins tend to run side by side, and in many places they also run with nerves. So we'll see a vein, an artery, and a nerve going in the same area and usually named for the same structure. Systemic vessels do not always match on right and left sides of the body. So almost all vessels in the head and limbs are bilateral symmetrical, but some deep, large vessels of the trunk are asymmetrical or unpaired. This slide here, you absolutely do not have to memorize it. I just wanted to show it to you. It's an interesting schematic of the whole systemic circulation, so don't get intimidated by it. You'll have blood vessels and the circulatory cardiovascular system as a whole other class, a whole other chapter. Just another overview here for you. Pause if you want to, otherwise no big deal for our intent and purpose here. So here's the arteries of the head, neck, and brain in that same kind of schematic version there, and I highlighted the right and left internal carotid arteries in the middle there so you could see where that is, and then you can follow that up as the vertebral arteries as well, and the circle of Willis if this type of schematic works for you. If not, go with the one that we've already just learned. Another overview for you here. So with any of these, go ahead and pause and take your time to kind of see where things are. This one I thought was a cool picture in the book, so it's colorized arteriograph of the arterial supply of the brain. It looks like a tree or coral. Another picture for you here that might be a little bit easier to study than the previous one. So different artists have different ways of presenting it, so you wouldn't need to memorize both of these. I mean, it's the same thing, but just work with one slide or the other, whichever one catches your eye better. Developmental aspects of blood vessels. So endothelial lining arises from mesodermal cells. So remember our endoderm, ectoderm, mesoderm. So mesodermal cells that collect in mass is called blood islands. Now blood islands form rudimentary vascular tubes guided by cues. So vascular endothelial growth factor, or VEGF, V-E-G-F, so VEGF. We talked about that in previous chapters and how it instigates growth. It determines whether a blood vessel becomes an artery or a vein. The heart pumps blood by week 4 of development in utero. Fetal shunts, or the foramen ovale and ductus arteriosus, bypass non-functional lungs. So these are parts of the heart that are open because the in utero fetus does not need to oxygenate their blood via their lungs because it is maternal blood that is feeding into that placenta, which is oxygenating the baby without the baby obviously having to breathe. Okay? So there's a hole in the system here because the baby doesn't need to use lungs to breathe. Another view here of the circle of Willis and surrounding blood vessels of that area. So we could see the internal carotid arteries and vertebral arteries. And this is from page 127 in the Nolte book. And I thought these were kind of interesting full body pictures of the blood vessels here to kind of put it in perspective for you. Arteries at the base of the brain. So the cerebellum and temporal lobe have been removed on the left side to display the course of the posterior cerebral artery. This view was selected because most of the arteries that supply the brain enter the cerebrum from its basal aspect. The 3 principal arteries of the cerebrum, so anterior, middle, and posterior cerebral arteries, arise from different sources. The anterior and middle cerebral arteries are branches of the internal carotid, while the posterior cerebral artery are terminal branches of the basilar artery. Basilar artery is from the 2 vertebral arteries. So the vertebral arteries, which fuse to form the basilar artery, distribute branches to the spinal cord, brainstem, and cerebellum. So we see anterior spinal artery and posterior spinal arteries, superior cerebellar artery, anterior and posterior inferior cerebellar arteries, or ICA and PICA, coming from that area. If one of the main vessels of the arterial circle rupture due to a defect in the vascular wall or an aneurysm, blood flows directly into that subarachnoid space and can result in a subarachnoid hemorrhage. I put this picture on the left in here next to this picture on the right in order to give you a perspective of that vertebral artery. So note the vertebral artery going through the transverse foramen, and then the vertebral artery over on the picture on the right, and then where that basilar artery comes together, just to give you a little perspective here. Same thing here, just to give you a little bit more of a perspective. So the circle of Willis will have some variance, as is evident on this MRA, which is a magnetic resonance angiography, as opposed to imaging. As you hear MRI all the time, there's MRIs of just regular imaging, and then MRA of the blood vessels. So kind of some interesting pictures there on the right of some variations. The anatomical basis of what we call subclavian steal syndrome. So subclavian steal is an interesting concept here. So it usually results from stenosis, which is a narrowing, a stenosis of the left subclavian artery located proximal to the origin of the vertebral artery. This syndrome involves a stealing of blood from the vertebral artery by the subclavian artery. When the left arm is exercised, as doing yard work or in the gym or whatever, insufficient blood may be supplied to the arm to accommodate the increased muscular effort. So the patient would complain of muscular weakness. As a result, the blood is stolen from the vertebral artery circulation, and there is a reversal of blood flow in the vertebral artery on the affected side. So this leads to deficient blood flow in the basilar artery and may deprive the brain of blood, producing a feeling of lightheadedness. The internal carotid arteries supply most of the cerebrum. So the internal carotid artery ascends through each side of the neck, traverses the petrous temporal bone, passes through the cavernous sinus, and finally reaches the subarachnoid space at the base of the brain. Just as it leaves the cavernous sinus, it gives rise to the ophthalmic artery, which travels along the optic nerve to the orbit, where it supplies the eye. So take a look at this picture here. We could see internal carotid coming up. I'll grab my highlighter so you can see that better. Internal carotid coming up here. And then you could see it branching off right here. We call this the ophthalmic artery. And it's going to give blood supply to our eye. I'll erase that and point out the optic nerve. This big yellow guy back here. We could see these little posterior ciliary arteries coming off of ophthalmic. And just little guys there. I have a picture on the next slide here, so this is basically the answer key, so it's a way to help you study. If it works for you, great. If not, you can just kind of skip right on through this, but if it works for you, go ahead and pause and go back and forth quizzing yourself on the blood vessel structures here. I find this to be a good picture to quiz yourself from, so I'm going to go ahead and read off what these numbers are correlating to, what structures they are. You can either mute me or pause this and quiz yourself, but I'm going to use my marker here, and we're going to go for number 1. Right here, you could see right here, also here, that hole there, is also labeled as, it's not labeled as 1 there, but it is number 1, which is the internal carotid. Number 2, go for green here so you could see. Number 2 is the middle cerebral artery. Number 3, I'll go for blue, is this right in here. You could see right here, number 3, anterior cerebral artery. I'm going to erase some of these so it doesn't get too crazy looking here. Number 4, this guy right here. See that little guy in here? Number 4, posterior communicating artery. Number 5, I'll use the dark blue. Number 5, right here, if you can see my marker there, that's anterior choroidal artery, C-H-O-R-O-I-D-A-L, choroidal artery. I'll erase it now. Number 6, down here. What is number 6? See that V shaped here? That's vertebral artery. Number 7. There's number 7 right there. That's pica, posterior inferior cerebellar artery, pica. And number 8. We've got pica and we've got its buddy, AICA, A-I-C-A, anterior inferior cerebellar artery. Coming up the line here, we can see, I'll use purple, number 9. Note that this is the pons here. So number 9 right here would be the basilar artery. Number 9, basilar artery. I'm going to erase some of this here. There we go. And I'll use my red marker for number 10. Cerebellar artery or superior cerebellar artery. Number 11. This guy right in here. Number 11, posterior cerebral. Posterior cerebral artery or PCA. So go ahead and pause, flip back and forth to the previous screen to kind of quiz yourself, test yourself. Do you know which artery is which? Great. This is just another study slide. It's a little bit bigger of a picture, and you can see the words on the left. So you can kind of cover that up if you like, or however you want to study this. Just a couple of different ideas for you here. Another perspective here, you have the numbered blood vessels over here that you can quiz yourself on. And then the addition here is where are they going? So anterior cerebral artery territory here, middle cerebral artery territory out here, posterior cerebral artery territory out there. Another perspective here on what blood vessel is feeding what area. So we can see anterior cerebral. Okay, so look at these dotted lines here. So see these dotted lines giving us our territories here. Okay. Okay, so we can see anterior cerebral is going to be this front area up here. Back here, posterior cerebral. In here is that middle cerebral. Pontine arteries makes sense because here's the pons. Okay, so we've got our medulla, pons, midbrain is this area here. Note this is the cerebral aqueduct right here. So this would be the superior colliculus, inferior colliculus, cerebral aqueduct. So third ventricle is up here. Fourth ventricle would be down here. This is the cerebellum. I'm going to erase that so it doesn't get too crazy looking for you here. And I'll move into a blue marker here so we can see vertebral artery is going to basically a little bit of blood supply all the way up, right? And then we see our SCA, superior cerebellar. See, cerebellum, superior cerebellar. And then we've got ICA, anterior inferior cerebellar artery, and pica, posterior. Oh, I got a little, there we go. We'll go green here. So posterior inferior cerebellar artery. So I'll erase all of that so it doesn't look like such a mess. So you can kind of check that out, pause that, and look at the different territories here. And that's pretty good. This is a picture from your book. It's a CT, CAT scan here of a 39-year-old hypertensive man, high blood pressure, of the lenticulostriate arteries, rupturing causing intracerebral hemorrhage, so bleeding. Okay? So when we see lenticulostriates, the first thing I think of is basal ganglia, basal nucleus. So that's telling us to look for that. The C here in the picture is the caudate, the L is the lenticular nucleus, and the T is for the thalamus. And if you look to the right, that starred area that I put there is, or maybe that's the book, this whole white space in here is that hemorrhage. So that is blood where blood should not be. This is page 134 in Nolte, and it is giving you an artist's view of the blood vessels. So if that's helpful to you, go ahead and pause here. So this is an interesting concept here, I thought, because it's not just stroke related. It is blood flow, different areas having different amounts of blood flow to different areas lighting up based on what they're seeing or doing, feeling. So this one's kind of interesting. So this is from page 140. It's the combined use of a PET scan, so positron emission tomography, and MRI, so magnetic resonance imaging, so PET plus MRI, to demonstrate changes in blood flow as subjects watch moving visual stimuli versus stationary stimuli. Each row of 4 images is from a different subject. Blood flow was mapped using the PET scanning after IV injection of H2150. An image of the surface of each subject's brain was reconstructed with T1 weighted MRI scans, and the 2 sets of data were co-registered. So moving visual stimuli activate an area on the lateral surface of each occipital lobe near its junction with the temporal lobe. Page 142 has this image in your book. So the light purple would be the anterior cerebral and anterior communicating arteries. The green would be middle cerebral, and the blue is the posterior cerebral artery. And then you can see the specifics over on the left in that middle area as well. So kind of an interesting perspective. So let's talk about stroke. So a stroke or a brain bleed or blood clot in the brain, so lack of proper blood supply to the brain. So we have a mnemonic on how to spot a stroke fast. It's FAST is the mnemonic. So how do we spot a stroke fast? It's face, arms, speech, time, tongue. So face, one side of the face will be drooping. Remember that a stroke is eyebrow sparing. So normally they will be able to raise their eyebrows. That's a sign that it's a stroke and not Bell's palsy. And we'll go through the specifics when we look at our cranial nerves. A is for arm weakness. We have the patient go ahead and bring both of their arms up, and you can have them palms up or palms down. And one side of the body, the arm will drift down. It's called drift test. We'll learn that in orthopedic tests. So arm weakness, one-sided arm weakness. Slurred speech or difficulty speaking is the S. T, time. Time to call 911. Count the time, so time counts. So note the time in which you came across this person and the onset of their symptoms if you know when the onset started, and make sure that you call 911, and when you tell the 911 what's going on, let them know the time, because certain medications can only be given in a certain time frame to be effective and safe. So time. And the other T, not necessarily listed here, but I put a picture of it, is tongue. Have them stick out their tongue. It could deviate to one side or the other, specifically if there is damage to the hypoglossal nerve, where again we'll get into the specifics when we get into our cranial nerve lesson. CVA, or cerebral vascular accident, is another name for a stroke. So we have a couple of different types of stroke. So 3 basic types. So hemorrhagic or bleeding, ischemic, lack of blood supply, think clot, and TIA, or a transient ischemic attack. So our ischemic here is going to be a thrombus or an embolus. So a thrombus is a clot in place. An embolus is a clot, a thrombus, that has broken off and now has moved to a secondary location. So we call it an embolus. So a DVT is a deep vein thrombosis. There's a picture of a leg there. You've probably seen legs like that before. That varicose vein, and then perhaps a clot in there as well. So it would be warm, it might be swollen, it might be tender to the touch, or hardly any symptoms or signs whatsoever. but it normally occurs, its most common occurrence is going to be in the calf, and that's a clot in place. If that dislodges in the example, it might travel up to the lung and be a pulmonary embolism. It could travel to the heart, or it could travel to the brain, and we would call that an embolus, a clot that has moved. Transient ischemic attack. We see normal blood flow on the left on the picture there and decreased on the right of the carotid arteries going up to the brain there. So transient is come and go. Ischemic is lack of blood supply, and then attack. So this might be a tiny clot that caused stroke-like symptoms. And then by the time they got into imaging, the clot was dissolved or moved and not visible anymore, and their symptoms went away. This might be a blood vessel spasm. And again, when they get into imaging, they're not necessarily going to see anything that's going to show up on an MRI or a CT. So they would do a CT for stroke because it's a whole lot quicker. And then if you're not seeing anything on CT, then that's usually after that they'll do an MRI, not for stroke issues, but for looking for other causes that might be giving off those same symptoms. So CT is for stroke. It takes, just a minute or two to do, as opposed to about an hour per body part of an MRI. A little bit more on that deep vein thrombosis. So you could see swelling, skin changes, maybe some ulcerative changes in the leg there. And then when we look at the vein has valves. Veins have valves, arteries do not. The heart has valves, but the arteries do not have valves, but veins do. And we can see the veins there, and the valves kind of close up a little bit in order to not allow blood flow to go backwards. So we see this deep vein thrombosis happening on the picture on the upper right there. So this blood clot is forming, this kind of blood stagnation happening at this area at the valve here. An aneurysm is different, in which it is this ballooning out of the artery, and then that aneurysm might rupture is the worry. And then there would be blood outside of the normal circulatory system there. And so there's a picture here of the aneurysm. It appears to be in the ACA, anterior cerebral artery. So think of it as a weak spot in a balloon that just balloons out and then hopefully doesn't burst. Another issue of the blood vessels in the brain that you might hear about is an AVM, an artery vein, arteriovenous malformation. And you could see it here on the left. Okay, so we could see this kind of mess right here, not very clear, distinct. See how you could see the lines of the internal carotid here, of the middle cerebral branch here, posterior cerebral branch there, and then what is that kind of blurry mess there? That's an AVM. So what's an AVM? It is where we don't see a good capillary bed. So remember we had the heart, the aorta, artery, arterial, capillary, venule, vein. Well, in between that artery or arterial and venule, we have a capillary bed where the blood gets kind of filtered out into that interstitial fluid, and then that interstitial fluid nourishes that area of the body. In this example here, it's the brain. And we don't have a good capillary bed here, if at all. And so in AVM, the blood passes quickly from the artery or arteriole to the vein, venule, bypassing the normal capillary network. So the issue here is you're not getting good nutrients to that area, but you're also not slowing the blood down. So that capillary bed slows the blood pressure down. So it's going to make it to where that vein doesn't have to deal with that much pressure. So without that capillary bed, it's not, the vein isn't very well protected. That system right there isn't very well protected, and that higher blood pressure could allow for an aneurysm of that AVM as well. the venous system here. So this is a nice picture here from your book. You could see the drawing on the left and then the scan on the right over here. So we're going to look at this a little bit more in a couple more pictures. Okay, so we see a superior sagittal sinus for number 1 right here. This whole thing, superior sagittal sinus area right here. Number 2, we're going to see a straight sinus. 3 is the confluence of the sinus. So think of where all of the blood would drain into. The confluence of like rivers, right, is where everything kind of drains into. So confluence of sinus is where that all kind of joins up there. So this is all venous blood, or vein blood in your veins, and this is we're going to use the word sinus here. So transverse sinuses. Number 4 here, we see some transverse sinus. We see the sigmoid, or when something kind of turns, we see sigmoid. 6 is the great vein. 7 is the internal cerebral. I don't see 8 on here. 9, internal cerebral. I don't see that, so let's skip to 11. We can see the transverse sinus here. So let's look at a couple more pictures and make this make sense. So our major veins of the systemic circulation, again, you don't need to know all of these, but it's just kind of a basics here for you. So you could pause this, look at this if you like. I'm not going to test you on it. It's not necessarily the brain, right? So up here would be the brain, right? And another kind of overall picture for you here of the major veins. Here's the venous drainage of the head, neck, and brain. Okay, so we saw our superior sagittal sinus, this area right here. We can see the occipital vein right here. We see inferior sagittal sinus. Okay, straight coming down, transverse, sigmoid, that turn, right? So you can follow this if this works for you. I have a couple more examples that might be helpful. This one here, okay, you could see ophthalmic. Okay, so we had an ophthalmic artery. We have an ophthalmic vein right here. So that's for the eye, drainage of the eye. Superficial temporal vein, okay, the temporal bone right about here. Okay. Facial vein, facial right here, the face. Occipital. Posterior auricular, so that's going to be draining the ear, right? So we would have an ear and then draining it. External jugular. Vertebral vein, we had a vertebral artery in that transverse process. We have a vertebral vein in there as well. We have an internal jugular vein right over here. You could see that. And then you could see the superior and middle thyroid veins draining the thyroid, this area over here. Brachiocephalic, so arm and head is what that means, brachiocephalic vein. And then big subclavian vein here, and coming up and around. And then superior vena cava going back to the heart. Okay, so we'll see that subclavian vein, a lot of importance there when we talk about the lymphatics and the drainage of the lymphatic system in other lessons, and how it drains into that subclavian vein. This one might make it a little bit easier, these kind of drawings here. So here's that superior sagittal sinus, okay, in between the right and left lobe of the cerebrum, or hemisphere, if you will. We could see the falx cerebri, okay, separating right and left cerebrum as well. Inferior sagittal sinus, let me erase this so you could see it. inferior sagittal sinus right here, straight sinus right here, and then we could see the cavernous sinus over here, and that's going to be this triangular space that we learn about in our cranial nerve lessons here. So it's going to have cranial nerves 3, 4, V1 and V2, so cranial 2 out of the 3 parts of cranial nerve 5, 6, and then the internal carotid as well. Doesn't have to make sense right yet. Just know that there's cranial nerves in there and the carotid in there. So we see that cavernous sinus area, and then transverse sinuses we could see right through here. And then sigmoid is the turn, remember? And then we could see this hole here in the skull being the jugular foramen, and the right internal jugular vein coming through here. This one's real easy. So we've got our frontal lobe up here, occipital back here, right hemisphere, left hemisphere, superior sagittal sinus. Easy. Only one thing that we're identifying here. Another picture from your book here to kind of put it all together for you. Feel free to pause and look at that if you like. Another perspective, same thing. Pause and look at that one if you like that picture. Another one from your book. So we could see the thalamostriate, okay, thalamostriate vein all the way up here, if you can see my red marker. Okay, so we could see this is the lateral ventricle, obviously, and then we're going to see the caudate here, because caudate is going to be peeking through that lateral ventricle. And then you could see the choroidal vein right here. What else is on here I want to show you? That's about it. We're good with that. Vertebral artery, basilar artery, and chiropractic. So we always have to talk about this. One of the things that gets associated with chiropractic every once in a while is stroke. There's a lot of debate on both sides of the coin here on cervical manipulation and the risk of vertebral basal artery stroke. So we need to know our anatomy here. So vertebral artery, remember that's going through the cervical spine. And then that basilar artery was the combination of those two vertebral arteries, remember. So vertebral is in here, and this is that cervical vertebra because we see it's bifid. We see it kind of triangular here in the big way that we know is we have this transverse foramen, the little foramen, the holes for vertebral artery and vein. So it's called a cervical artery dissection, or a CAD, if we see, or a vertebral artery dissection, you could see it called that, VAD. If we see some sort of dissection or breaking apart, if you will, of this blood vessel, of this vertebral artery. So if you look over here, this guy right in here is the troublesome one. And basically, an older patient, especially, I mean, this could happen at any age, but an older patient, maybe they've never been adjusted before, maybe they've been adjusted a lot of times, but think of someone that's never been adjusted before. They've got a C3 body left that's been sitting there forever, and the body has accommodated for that. And we go in there and we do a big high velocity, low amplitude rotary brake right at that C3. What signals are going to be sent to the body? It's going to feel kind of traumatic if it's been sitting there for 20 years like that, right? So we don't want to do that. We want to assess the patient and then give an appropriate adjustments. So slowly start to bring the body back into a better alignment, just like working out, right? So if you've got a 60-year-old patient that's never worked out a day in their life and they want to start working out, you're not going to have them run a marathon. You're going to have them walk first, maybe a half a mile, right? And then live to see another day and want to do that again. So the same kind of concept has to be applied in adjusting the body, in my opinion here. So take it slow and assess the patient, but you'll get this in a lot more lessons as well. I just need to touch on it if we're talking about blood supply to the brain. So I have an article here for you to read about vertebral artery dissection and cerebellar infarction following chiropractic manipulation. So as chiropractors studying the blood supply to the brain, we have to understand the risk of vertebral basilar artery stroke and dissection. If there's a risk, and what is the risk, and what can we do to minimize it. All of these will be covered much more in depth throughout your education, but we need to touch on this a little bit. So I wanted to introduce this article to you, so we'll read it. I'll actually read it to you on the next slide. And if you have any opinions or want to discuss it with me, please email me. I would be happy to discuss it with you and listen to any of your thoughts on the article. I'm going to refrain from giving you my thoughts on the article and just read it to you, and then if you want to have a discussion, I would be happy to do that, but I don't want to influence your thoughts on it by giving you mine. So let's go ahead and go on to the next slide here. Vertebral artery dissection and cerebellar infarction following chiropractic manipulation. This is an article from 2006 in an emergency medicine paper publication here. So it's going to have a certain slant to it because it's emergency medicine, not written by a chiropractor, so medical doctor. So I'm going to go ahead and read the entire paper to you. So if you are an auditory learner, that might be of benefit to you. If you do not like that style of learning, go ahead and pause or mute and just read the paper on your own. So we'll go ahead and start. Vertebral artery dissection, or VAD, associated with chiropractic cervical manipulation, is a rare but potentially disabling condition. In this report, we present a young patient manifesting with repeated vertigo. Owing to an initial misdiagnosis, the patient later developed cerebellar stroke with inability to stand or walk. Vertigo and disequilibrium are the usual presenting symptoms of this condition, which can result from inner ear or vestibular nerve dysfunction, vertebral basilar insufficiency, and even lethal cerebellar infarction or hemorrhage. These last two, although rarely seen in young adults, can be caused by traumatic or spontaneous arterial injury, including injury secondary to chiropractic cervical manipulation. A number of cases of VAD associated with chiropractic cervical manipulation have been reported, but rarely in the emergency medicine literature. We present a case of this rare occurrence and discuss the diagnostic pitfalls. Vertigo and dizziness are among the commonly encountered symptoms presented by patients attending the emergency department. Some of these patients, especially the elderly, have vertebral basilar insufficiency, or VBI, and even lethal cerebellar or brainstem infarct or hemorrhage. However, complications arising from chiropractic manipulation, especially vertebral artery dissection, may be seen in younger patients, causing VBI or cerebellar or brainstem infarct. This condition is rare but clinically significant, as its rarity and sometimes clinically atypical presentation can lead to misdiagnosis with possible lethal outcome. A 28-year-old man in good health visited a chiropractor for treatment of neck pain for about 2 weeks. Following one of these chiropractic manipulation sessions, he began experiencing vertigo and attended our emergency department immediately. On arrival, the symptoms had disappeared spontaneously. Physical and neurological examinations were essentially normal, and he was discharged with an appointment made for follow-up at the outpatient clinic. The following day, he experienced another episode of vertigo, along with loss of balance, blurred vision, and mild numbness and weakness of the left extremities. He was again referred to our emergency department. Physical examination revealed a young man who appeared well and was alert and cooperative, except for an inability to tolerate sudden changes in position. Blood pressure was 146/76 millimeters of mercury. Pulse rate was 90 beats per minute. Respiratory rate was 18 breaths per minute. Ear temperature was 37 degrees Celsius. He denied any episodes of headache, syncope, head or neck trauma, and the use of recreational drugs. Neurological examinations, including motor and sensory function, were essentially non-focal. However, the patient could not stand or walk because of vertigo. Cerebellar testing, including finger to nose, rapid alternating movement, and heel to shin, were impaired on the right side. Routine laboratory studies, including blood tests and electrolytes, were within normal limits. Electrocardiography showed normal sinus rhythm, and cervical spine radiographs were normal. While retaking his history, we found that he had experienced several episodes of vertigo after cervical manipulation, thus under high suspicion of cerebellar stroke associated with acute vascular injury. Doppler ultrasound of the extracranial artery was performed, which showed trickle flow over right distal vertebral artery. Magnetic resonance imaging of the brain revealed a tiny lesion over the right cerebellum with high-intensity signal on T2 weighted image, which showed as a bright area on diffusion weighted images and dark on apparent diffusion coefficient mapping, most likely a tiny recent or acute infarction. Angiography of the vertebral artery revealed occlusion of the right distal vertebral artery near the cranio-cervical junction. Vertebral artery stenting was tried, but failed to pass the distal true lumen. The patient was admitted to neurological intensive care unit and placed on anticoagulant or heparin. On the 8th day, he was discharged without any sequelae and followed up regularly at our outpatient clinic with oral anticoagulant therapy. Discussion. Chiropractic spinal manipulation is a popular alternative therapy for neck and back pain, which is performed by chiropractors who tend to believe that it is not associated with relevant risks. However, in 1947, Pratt, Thomas, and Berger reported 2 patients who became unconscious during chiropractic adjustment and died under 24 hours. Since then, the risk factors and complications of chiropractic manipulation have been under discussion, and the opinion that chiropractic spinal manipulation is risk-free has been contradicted by findings in the published literature. The most frequently reported complication is posterior circulation stroke, usually related to VAD, occurring during or shortly after cervical manipulation. Some diagnostic pitfalls should be noted for this condition. Firstly, because of the unfamiliarity and rarity of this condition, there is a possibility that medical staff will fail to elicit a history of cervical manipulation. The specific questions regarding spinal manipulation were not included when the patient first made his first visit to the emergency department, and it was not until the second visit, with the patient showing recurrent vertigo and disequilibrium, which might be the signs of VBI, that the cervical manipulation history was discovered. Secondly, this condition may show a fluctuating course. The etiology of vertigo is classically separated into peripheral and central types, because the neurological examination of our patient on the first visit was essentially normal. and he was a relatively young patient without any risk factors of stroke. He was discharged under the impression of peripheral vertigo, a fluctuating clinical course, as in our case with normal findings, and at certain time points in the course of the condition may also contribute to misdiagnosis. Some authors are of the opinion that brain ischemia is delayed by hours or even weeks after injuries. Thus, the presence of such a delay provides a time window during which measures could be undertaken to prevent thromboembolism and to maintain vessel patency. The vertebral basilar infarction associated with VAD may significantly contribute to disability in surviving patients and may even have legal implications. Early diagnosis and management is therefore essential. Anticoagulation and heparin followed by warfarin is the treatment of choice. Surgical intervention is indicated only for those patients with persistent symptoms refractory to medical therapy. Endovascular treatment, balloon angioplasty followed by placement of stents, has largely supplanted surgery as the initial therapy of choice in cases where medical therapy fails or is contraindicated, and even instead of medical therapy for many asymptomatic patients. Smith et al. Have suggested that chiropractic manipulation independently increases the risk of VAD with stroke by approximately 6-fold. Rates of VBD following cervical manipulation from 1 in 10,000 to 1 in 2 million have been reported, but the exact incidence is still unknown. However, this diagnosis should be considered in patients presenting with recent onset vertigo and loss of balance, and history taking should include questions on presence or absence of recent spinal manipulation. These are the pictures included in the article. So you could see I have my red pen here. I'm going to just outline where that white arrow is in red so you could see it, and they are talking about that tiny little infarct is creating that problem for that patient. And then you can see down here as well. So you could see collarbone is here, vertebral bodies, spinous process. Okay. Up top here, this is the cerebellum. Okay, these are ears out here just to kind of orient you on where we are here, and this is the nose up here. Okay, these big black spaces here, that's sinus. Okay, sinus space here. It's got a little deviated septum there. Okay. Congratulations, you have made it to the end of Chapter 6. Make sure you check out the quizzes on the webpage, and I will see you for the next lesson.